So, good afternoon, everyone. This is the 19th edition of the Healthcare Insight series by Healthcare Sector Skill Council, which we regularly do every month on a uh, on a very important topic in collaboration with the industry members, the experts, the healthcare experts, and we really welcome all of you and very thankful to all of you to keep joining our informative sessions every month and joining HSSC for this important initiative. Today, we have two esteemed speakers with us, Dr. Nagesh Simha and Mrs. Sangeeta Murugan. They are going to take up the very important topic, overview of palliative care. We all should know that what is palliative care and how it has to be given and what important role we all face as an caregiver if any patient is there at our home or our healthcare facility. So thank you so much for taking up this very important topic. Just to introduce, Dr. Srinagesh Simhaji is a general surgeon turned palliative care physician. He is the one of the founding members and current medical director and trustee of Bangalore Hospice Trust, Karunashray, and Bakchi Karunashray Palliative Center, Bhubaneswar. He is also an honorary tutor in School of Medicine, Cardiff University, and adjunct faculty with Department of Palliative Medicine and Supportive Care in Kasturba Medical College. He is also the advisor to the Union Health Ministry and to the states of Karnataka and Odisha. Thank you so much, sir, for joining in today. We also have one more speaker, Mrs. Sangeeta Murugan. She is Head of Nursing Education, Bangalore Hospice Trust, Karunashray. She is also the National Faculty in Palliative Care, LNEC Trainer, India, and also the President of Indian Hospice and Palliative Nursing Association. With her 23 years of experience in clinical nursing education and palliative care, she is here along with Dr. Srinagesh Simhaji to take up this very important topic of overview of palliative care. From my side, I am Dr. Megha Agrawal from Healthcare Sector Skill Council. I welcome both of you and hand over the stage to you to take up this very important topic. And request all the audience members to keep yourself on mute. Also, keep posting your questions, queries on the or your inputs or suggestions on the chat box. We would surely take up all the queries after the session being completed. Thank you so much, sir. Over to you, both of you.
Thank you, Dr. Meha. And thanks for your kind introduction and telling about palliative care in one word. And here, Dr. Simha and I are there. We both are going to take the session. I'll start my session, and meanwhile, Sir also will join. Yeah, I'll share my slides. Would you, are you able to see my slides here? I'll make it slideshow. 1 second. Is it fine?
It is visible, but it's not on slideshow right yet.
Now I made it.
Yes.
Yes.
It's fine,
Okay,
Sangeeta. Go ahead.
Yeah, thank you, sir. So, good afternoon, everyone. As Dr. Meha said very rightly, we are going to learn something that touches every Indian family. That's why I'm not starting my session with the statistics, and I'm not starting with the definitions, and I'm going to start with the story, because the topic what we are going to learn today is very more interesting, and most of the time people misunderstood, especially the chapters what is there in the modern medicine. So that's why we decided we will talk about palliative care. And many of us, every day we see patients in our routine life and in our clinicals. It's very common. We diagnose the patient, we treat the patient, we operate patient, we prescribe, we administer medications. But there is one question in a medicine, either in medicine or nursing, we often forget to ask, right? What happens to the person living with that illness? That is what, we are going to learn today. I would like to take you through the real life case scenario, step by step, and, for you to understand and help us what we are doing in this field of palliative care in a very simple way, humanistic way. to understand the concept. End of the session, my goal is at least, you should care one patient, one family in your healthcare setting. That is what my expectations. Because it's very sensitive topic and illness, it's not only for a patient, it enters in every single room, and it's not only affect the only a body, it affects the entire family. That is what the importance of palliative care. So before I start, I just wanted to introduce our setting. So this is what we have been having in India. One center in Bengaluru, that is Karunashaya, which is there in Bangalore. We have one more center in Bhubaneswar, which is Bakshi Palliative Care Center. We have two centers, leading hospices we are running in the country. So you are all like this. What is palliative care? Because curiosity is always should be a engine to achieve everything. So in this session, this is my objective. What is palliative care? When to start, how to provide, who has to provide, where to provide, what is the right time to start palliative care. So with this introduction, let me introduce Meera to you. Okay. Meera is one of our patient, a school teacher, mother of two children, 8-year-old and 12-year-old. One morning, this Meera, when she was taking a bath, she felt, some small hard lump in her left breast. And, she just left. She didn't take it so seriously because the work is a priority. She ignores for a week. She thought that, okay, it will go well. It doesn't matter. Finally, it was not going. Then she gathers a courage and she goes to the hospital. The doctor examined her and he asked her to go for mammogram and then biopsy, repeated test. And she came with one brown cover sitting in the hospital corridor. And her hands were shivering. The doctor called her and said one sentence. The doctor said, "I'm sorry, it is cancer." And he just said that word, and everything inside her collapses. Her ears stopped hearing, her mouth became very dry. She thought very immediately one thing: what will happen to my child? This is the only one thought it was echoing. And that night she didn't sleep, and she stares at the ceiling in her house. She was, completely collapsed. And then the real marathon started. Okay. And the treatment started. She started all the treatment because she needs her life back for her children. She undergone 6 cycles of chemotherapy. She underwent a mastectomy. Then routine chemotherapy, radiotherapy has started. And she visited, hospital back to back, and a lot of money invested. She was taking leave from her work and arranging a child care, to look after the children. But she was a brave lady, but inside, she was breaking badly. And whenever she goes to hospital, everyone was busy and rushing. Doctors were focusing on test, investigation, prescribing the medications. Nurses were focused on taking vital signs, doing the procedures. But her own family, was focused only on a survival because she was at the right age where family needs her. Right. And, when she was undergoing all these things, obviously, she was declining very badly. And despite taking all the treatment, what happened? She was 1 year, she was all right. Later, the recurrence happened. Cancer has come back. This time she became very bad. She started with breathlessness, severe pain, and repeated admissions happened, on and off to the hospitals. Disease has progressed very badly, multiple metastasis. She had got spine mets, liver mets, everything, and pleural effusion was there. And what doctors were saying in the hospital, they said, we'll do one more CT scan, one more bronchoscopy. And later, when she was deteriorating very badly, she was shifted to ICU, and round of antibiotics, IV infusions, everything was started. And this time, the family was really exhausted. Not only, about her illness, they were financially, emotionally, socially, they were completely exhausted. And but what happened, one Sunday morning, and one of his doctors said, "Why don't you try palliative care? Because we couldn't help anything. Just try. There is nearby one center is there, and go and visit." That's when this Meera came to Karunashaya. She came with us And how we saw her is her respiration rate was high, pulse was high. There was terrible pain. She came with a severe pain, uncontrolled pain. The score was 8 by 10. She was in anxiety, restlessness. The mouth was dry. There was a fear in her eyes. And we also saw her family, right? The husband was shaking. He doesn't know what will happen to her. And, Meera was saying, "Don't leave me alone. I'm so scared." That is what the sentence she said to husband. And children were crying outside. She asked one thing to our team: "I want to breathe. I want to sleep. I don't want to suffer." Okay, this is what she said to the healthcare team. And this is the case, this is how we see every day in and out in our center. And this is not only one day, all most of our patients are like this, right? And many a time as a healthcare professionals, we understand how to diagnose the disease and how to treat the disease. Many a times we don't know when death occurs, how we have to provide care to the patients. So we need to, before we go into the topic, we need to understand what is the trajectories of dying, right? And you could see patients, sorry, somebody is doing something with my slides. Okay, patients are with the disease when they are in the dying stage. What happened? Look at the first picture. The slides, clearly explains if the patients are in terminal illness, right? The patients are in, disease like cancer. Their life is like this. They function well for a long time, the disease like this, but the decline will be very bad. That go into the treatment, they'll deteriorate very fast. And here, you have lot of time to provide care to the patient. And the disease like organ failure, like it is like the patient get discharged and they'll have decline. It is like a waterfall disease, and they'll be being well for some time, again they'll fall sick, and again they'll deteriorate. This is how the patients with organ failure will happen. But you see the last picture which is there in the green line, it shows frailty. The patient, they'll get old. The decline will be happens in a priority basis, and they lose the speech, memory, they'll slow in walking. All these things will happen, and one day the patient will die. And in all these stages, palliative care is important. Our goal, is not about to treat the disease. Our goal is to how to reduce the suffering. It's very important. The very primary thing in palliative care is how to talk to patient, how to communicate. That is what we play. The goal of palliative care is. It is not here the answer. It is not about what is the time left and what is the need the patient is having, the time what they have. So, but one thing, it's not possible in palliative care when the patient's dying suddenly, that we could not do anything. But in all these trajectories, in this dying stage, we have enough time to provide comfort to the patient. Why the palliative care is very important? My statistics in the world, it says this: still today, it is as per WHO. This data is from WHO. As per WHO, 86% of people, they are not access to palliative care, and 83% they are not even access for the pain relief. And very poorly, the country like India alone, middle income countries, 98% are children. They are terribly suffering with the terminal illnesses. And very sadly, only 14% of people in the world, they are receiving palliative care. And if you see that India only 0.7%, okay, of the global medical morphine, despite we have 17% of world population. This is the scenario. That is why we need palliative care. If you come to an Indian statistic, if you take only cancer, exclusively cancer, you know very well, Karunashaya is the place where we provide palliative care only for cancer patients. The reason is we see more than 1.5 million new cases every day as per ICMR report, recent report it says, and every day 76% of cases are having advanced stages, and the curative possibilities are very less. If you see Non-communicable diseases. This is one side about the cancer. If you see the non-communicable diseases, over 63% of total deaths are India. It's mainly because of non-communicable diseases, and lot of things involved: heart failure, COPD, whatever it may be. All these things, require palliative care. Even dementia today, the statistics are more the patients with dementia. So the overall need for palliative care, as per Lancet Commission report, in India only, the need is more than 7 million people require palliative care only in India, but the access today is less than 4%. If you see the palliative care need, especially the recent ICMR report, in the last picture you can see less than 2% of people accessing palliative care, and the pain, people are getting opioid is less than 1%. If I say in a normal word, imagine if there are 100 Indians who suffer with pain, breathlessness, anxiety, fear at the end of life, 96 of them out of 100, they are not getting proper palliative care, right? So this is the gap we are trying to fix, and we want to sensitize you all into palliative care. In the slide, the lady who is there, she is Dame Cicely Saunders, and she is the founder of modern hospice and palliative care movement in the world. And she started, and basically, if you see, she is a nurse and she is a social worker, and she is also a physician and writer. And she started this movement. And when she started, she said this single sentence. She said that you matter because you are you right up to the last day of your life. Because this single sentence changed, the whole world understands how much the care is important till the end of life. It reminds us the patient, values, very important. It does not reduce when cure is no longer possible. So, family may regret, so people will die, but family may regret, and they also forget, the taste what they have done, the hospital days, but they never forget how the loved one died and how the loved one was treated and taken care of, from the healthcare professionals, the doctors, nurses, during the last day. We may not change, the outcome of the illness when you provide palliative care, but sure, you can always change, the experience of their journey, the experience of the dying. The philosophy and is the foundation of palliative care is, it starts from the diagnosis. It's not at the end of life. You have to start palliative care from the diagnosis and to the human care. And from that moment, the first hospice started in the world in the year 1967, which is called as St. Christopher's Hospice, which is there in London. And in India in 1986, it was a Shanti Avedana Hospice in Mumbai. These two are the first hospice in the country. We started Karunashaya in the year 1994. We started as a home care center. Today we are 31 years old, leading hospice in the country. Our first inpatient started in the year 1999. And the chronic illness, the burden is so much. The chronic illness, it's not a single event. It is a long journey, huge journey. The burden is so much, and the burden will increase over the time. Many patients tell us, one thing: I am not afraid of dying. They tell us, I am afraid of suffering. Right? So look at the sufferings. It's not only physical when you see. So even in Mira's case, it is not only physical. It is about psychological, about children, the spiritual, financial issues, social issues, so many things. What we do as a palliative care professionals, this is what we will be doing. Look at the picture at the right side. We will, take care of the patient. We reduce the suffering. We share the suffering. We will discuss with the family. When it comes to a chronic disease, it becomes a family disease. It's a family, the one family member will become a full-time caregiver. They'll have loss of income, the children will be suffering, they'll have guilt conscious. This caregiver also will suffer silently. This suffering is more than what the patients are suffering. So we'll reduce the suffering of the patient. That is why I put very specifically, the palliative care is not only a patient, it is for reduce the suffering to the patient as well as family. And palliative care is not only with the physical. So there are a lot of other dimensions, right? So the palliative care exists today because to reduce the burden. So what happens? It's with physical. Okay, palliative care take care of all physical aspects, psychological aspects, and social aspects of the patient and the spiritual aspects. And it involves, with involving all these things, we provide a holistic care to the patient. Until today, though the palliative care is proving very well in India, but till today there are a lot of myth and misunderstanding is there in a palliative care. People think that palliative care is only for a dying people. No, palliative care for all the people. It should start. The palliative care begins at the time of diagnosis for any serious illness. You can give chemotherapy, you can start dialysis, you can start palliative care for heart failure patient. There is no limited, the palliative care is not only limited for the last day of the patient when they come to us. And not only this, the people think that palliative care means you have to send the patient to palliative care when nothing can be done. No, palliative care, it's not that when you can do many things with the palliative care. So when the curative care will stop, but the care will not be stopped at the time of palliative care. And people think that palliative care, shortens the life. When you send the palliative care department, people will die. No, the evidence is showing that the WHO clearly says, I will come up with the definition. It improves quality of life. Palliative care, it improves quality of life. It reduces this distress from the patient and the family. It controls the symptom effectively. And in one word, I wanted to say, we are not adding years to the life, whatever the patient with a disease condition, we are adding life to the time what they have. That is what called palliative care. Look at this picture. So I didn't write anything in this. I wanted to explain. So you understand if somebody is holding a glass in their hand. Imagine if I hold this glass of water in my palm, I can, I won't find any difficulty if I hold for 1 minute. Oh, it is very easy. It's very nice experience. But if I hold it for 1 hour, you know what happens? My hands start to ache. Okay. If I hold it for the whole day and maybe a week, my hand will, become numb. I can't do that. Okay. Imagine here you have to take a pass and think. Okay. Here it is not weight of the glass. Weight of the glass has not changed if it is 1 minute, 1 hour, or whole day, whole week. But the thing is how long I am holding it, right? The thing is changed with the time. Same principle applied to the people, those who are with any serious illness or chronic illness. The symptoms are like a glass. The patient will have a chronic pain, chronic breathlessness, chronic fatigue, lot of fear, uncertainty will happen because of the disease. Holding these, symptoms for a day might be okay. If it is week, if it is month, it causes immense suffering for the patient and even for the family also. Most of the symptoms are very much manageable, but what family does, they isolate, they find a burden. So as a role of a healthcare professional, okay, you can't take it as a task of a patient. You have to help them. We are helping them how to put this suffering down, how to keep the glass down without breaking the glass. That is what, we want to make this suffering very lighter, and we want to provide, the comfort to the patient. Suffering is easy. Suffering is not about the intensity. It is about duration. That is what we want to reduce the duration. We want to, give comfort to the patient. So this is what, in a simple way, palliative care. People think that, look at this first, like when the treatment are not responsive, start palliative care. No, today you start palliative care at the time of diagnosis. And palliative care provides relief to all symptoms. People think that most of the hospitals I used to see, palliative care means pain and palliative care, reduce the pain. It's not only pain, it's all about all other symptoms. Could be a breathlessness, could be, severe nausea and persistent vomiting, whatever it may be, it reduces the symptoms and it improves quality of life. And palliative care ensures good end of life care patient. All you need to understand is palliative care is an extra layer of support to the patient as well as family. This is your WHO definition. It's a huge definition. I just break it into 4 points. All you need to understand end of the session. Palliative care improves the quality of life of patient by providing comfort to the patient and reducing the symptoms. Palliative care is not only for cancer, it is for all life-threatening and life-limiting illness. Palliative, what all you have to do is early identification. Most of the times, I told you, no, the Meera case, she came at the last moment, last 48 to 72 hours. She died peacefully, but what happened? We don't have enough time to provide good palliative care. So early identification, impeccable assessment and treatment are important. And what I said earlier, palliative care involved with all the dimensions, physical, psychological, social, and spiritual. If you come to Karunashaya, you could see the palliative care, how many number of doctors we have. We have same number of counselors, because it's not only a physical care. When the patients are in this critical stage, they need more and more psychological issues. So we need to address it. So all these aspects are very important. So palliative care is like this. Look at the diagram at the left side, what WHO said very easily. Your curative aspect along with palliative care, join the hands, provide care to the patients. Yes. So this is the concept of palliative care. For many years, people thought that understood in a narrow way. But today, the concept, the understanding has completely changed. Earlier, they thought that you start palliative care. See, patient get diagnosed in the old concept. They give all the curative management. When they become critically ill, they start palliative care. The patient comes to palliative care department. Then eventually the patient dies. But today it has changed. The concept is start palliative care at the time of diagnosis, right? Early palliative care was introduced. So you start, so what happens? It is like adding extra layer. The curative treatment will go and you are starting palliative care meanwhile. So what happens? You are focusing the comfort, you are reducing the late referrals. The symptoms are controlled very well. Family, the team will communicate with the family will be prepared very well. And so it has changed, like a palliative care, it is not like a lost stop, it is like a part of journey. So you are adding a layer of support, during the illness of the patient. So in an old model, people ask when we should stop the treatment. But in a new model, it is about how to provide quality of life at every stage of the illness. With the evidence, I'll prove this. Look at this paper, what it is saying. See the transition in the chronic illness. You know how the palliative care started at the time of diagnosis. Look at palliative care is going parallelly along with the treatment and palliative care. It's not opposite. We are working together. Disease progresses, right? Here the disease is progressing. See how the patient is getting declining. Initially, the patient is functioning very well, and slowly, when the transition is slowly declining, right? So what happens? We start, the symptom management. We start with our communication. We start with our advanced care planning. We talk to family caregivers. Even we plan for see, when the transition 4 happens, this is where the hospice care will start. This is what Karunashaya plays a role. People like having hospice setup, we will start our care, and patient will be in a terminal stage. They come, we face the dying stage, we handle death, and we'll continue our care with the bereavement. So our care stops till bereavement. But as the disease progresses, all need to know is start the palliative care at the time, not at the time of diagnosis. Never start with zero. Okay, so that is very important in palliative care. Here, in every chronic illness, there is a death, right? It's invisible. Here, there are 3 circles. It is not separate services. People will have lot of confusion. Palliative care means end of life care. No. Look at the outer circle. It is palliative care. It is a large circle. With this, you have to start from the diagnosis for any serious illness. It runs alongside with all active treatment. You can provide quality of life. You can start your psychological support, family support, and most of the patient's journey will happen here in the outer circle. And when it comes to end of life care in the middle circle, here the patient is seriously deteriorating. The illness has progressed very badly. There will be very less time, weeks 2 months, and then the focus shifts from the care. I'm sorry, my slide got disconnected. 1 second. Someone else is sharing. God. So, once again, I'll share my. So this is what about, all these circles. This is here what happens. So the patient, here really we start with our, where is the place of care the patient want, how we have to provide comfort to the patient, how we can prepare the family emotionally, So in this stage, what good palliative care makes this phase very calm instead of making more chaotic. And this is very, critical stage, the final hours, the inner circle. So what happened? It is, very limited time. The patients are actively dying. They will show all imminent signs of death. All you have to do is how to manage these terminal symptoms, how to provide the assurance to the patient, how to provide dignity to the patient, because this phase is very short, but it leaves, lifelong memory for the family. So it is very crucial time where hospice plays a major role in this phase. And there are domains in palliative care as per NCP guidelines. So you need everywhere the structure, the steps. Palliative care starts with a good structure and process of care. This good care, it does not happen with chance. You need to have system. You need to have clear referral pathways, how to continue the care from the hospital, from home to hospice, because it prevents, the fragmented and last minute crisis and care and everything. That is why you need to have a structure and process of care. The second thing is physical aspects. As I said, when the patient are with a chronic illness or terminal illness, they have a lot of physical. Unless you control the physical thing, you can't enter into other aspects of care, whether it may be, the pain or breathlessness or delirium or nausea, whatever it may be. Timely assessment and reassessment is very important, because if you don't do that, uncontrolled symptoms, destroy the dignity and trust with the team. And your third step is psychological and, even psychiatric aspects of care. Because when you handle a patient in this stage, a lot of fear, anxiety, depression, these things often hurts more than the pain. Patient will go into emotional distress. They lost their coping mechanism. They really need a mental health support, because if you don't do this, treating the body alone, you're providing an incomplete care to the patient. There is no meaning in that. That is why there is, importance of involving psychology and social aspect. Because if you take an Indian concept, I'm not going to the country world, take an Indian concept. Any person falling to, any illness, it becomes a family event. They look for a financial, resources. They have that stress. Caregiver burden will be there. The stigma is so much. The cancer with the wound and everything, isolation will be there. So you need to do this when, you need to incorporate all the social aspects, because it reduces the social distress, because it directly worsens the physical suffering. So you need to address that also. Very importantly, most of the time, we don't ask and we don't involve. I have an expert with me today. Dr. Simha is very experienced and expert in talking about communication and spiritual aspects. He will add a lot of inputs end of the session. And this is the one question all family will ask us: why me? How long I have to take this medication? What is the meaning in my life? Why I had all these beliefs. I respect all my beliefs, God. Why happened to me? So it is important, you should give that spiritual space to the patient when they have fear during their end of life. And this aspect, the sixth point, is very important, especially in our country, because we are with the lot of cultures involved in our country. because any patients, falling sick, all the cultural aspects involved, decision making will become a problem. Family dynamics will be there, cultural mismatch, mistrust, poor decisions. I can give a lot of case scenarios. We had a lot of issues happened, with the patients. It's handling this is a very important in palliative care. And the patient with end of life, especially working in hospice, this is a core. Hospice is a heart of end of life care. The last days is very matter because it's remembered forever, as I said. Because how to control the symptom, how to provide comfort, importantly the dignity, how the patients are dying, it's matter. Still remember, our chairman one day visited our wards, surprisingly. The nurses were packing the dead body. And I heard this from the nurses. He was peeping through the screen what the nurses are doing. They're packing the dead body, but still, one of the nurses lifting the head of the patient, other nurse is slowly pulling the pillow. It shows that how much they are providing dignity. Even the patient, is not with us no more. And that is very important. That is what a core principle in palliative care, because this shapes, the family, memory and comfort, and they don't have that guilt. I could have tried this, I could have tried that. That thing we would be reducing. Very important today in this era, in this medical scenario, the ethical and legal aspects. Doing right thing is very important. It's just because you're doing something. What you are doing, it should have rational. You need to have informed consent. You need to have goals of care. You need to why you are avoiding a futile treatment. All these things have to be documented, and you need to protect patients' autonomy and clinical integrity. And it's very important when you provide palliative care means to do something. It's not that why I'm doing what I'm doing rightly to the patient. If you miss even one domain in all these things, 8 domains, suffering increases. So palliative care works efficiently because we are working with all these 8 domains together. So this is very important. People always think that palliative care is only for cancer. Even in Karunashaya, we provide palliative care for cancer patients because we are committed to provide care to cancer patients. But look at the study evidences. Today, most of the deaths are happening because of the cardiac diseases. Palliative care for everybody, either it is cardiac, COPD, or motor neuron disease, or dementia, Alzheimer's, whatever it may be, everybody needs palliative care. What we provide in palliative care, we control symptoms. As I said, all these symptoms will be controlled. We also managing disease. The patient will be with the different diseases, cardiac disease, renal diseases, emergencies will be there. All we do is correct the correctable first. And we ensure the patient is having good end of life care. As I said, dignity, and as I said, the patient is having good pathway, and we provide good death and continuing breath. All these 3 aspects will happen only because of the corner, right corner yellow box, communication. Without communication, nothing is possible in palliative care, because the final line is end of the day, you are not going to give a good news to the family. You are going to give a bad news. You are going to say your loved one is no more, right? When you want to say that, you need to have excellent communication skills to handle all these things. And this is what the statistics says. Look at the rates. Who provide? Palliative care is not a one-man show. Many of the hospitals and healthcare system, you could have seen, the doctors will take a decision and they'll write the order and the team will carry out. But here it is changed. Here it is multidisciplinary team. The team should work. It should be involved the doctor, nurses, counselors, physiotherapists, even social workers, how to, sort out social issues, how to provide support to family members, connect with the different NGOs. Even most of the west side, they'll have chaplains to add spiritual issues. In hospice, we will call the experts to talk. Sometimes priest will come to address the issues. So you need to have a multidisciplinary team to provide good and effective palliative care to the patient. and where the palliative care can be provided. It's not only in the hospice. Don't think that if you want to give good palliative care, you have to come to Karunashaya or you have to go to any centers, hospitals where they have palliative care is there. You can start palliative care at your bedside where you are working, where you are doing. So you can provide palliative care wherever you are there. It could be a hospital, it could be a clinic, it could be a home, or wherever you are working. All you need to have good compassion, need to understand the patient, timely referrals. I'll tell you how the timely referral will help. You know, a lot of principles involved in palliative care. As I said, it is not only for pain, it is for all the symptoms. It is not only for dying patients, it starts with the diagnosis. We are not postponing the death here, and we are not handling only physical symptoms. We are not handling only patients. We are also taking care of caregivers, family. We are, involving the team to provide good palliative care. And our files will not be closed only with the death. We'll continue our care with the bereavement support. Okay, we'll start our journey from the diagnosis to the bereavement. Okay, it is not a final line, it is a lifeline palliative care. That is what you need to take it. And with understanding all these things, we started with Mira case, right? I wanted to tell how we have incorporated all these dimensions. So I said, oh, again, my slide got disconnected. Once again, I'll share it. You can see my slides, right? So we started with this, and what happened?
Sangeeta,
Yes,
there's not
sir.
much of time left, okay?
Yes, sir.
I
I'll
think
complete.
it's at if it's till 1 o'clock, I think you should finish in the next 1 or 2 minutes because we should
Yes,
give
sir.
them time to ask questions.
Yes, will do. So the
Thank you.
physical aspects, we managed all the symptoms. Psychological, you could see we reduced our anxiety, we coped with the family. Social, you can see how we helped them to understand the disease and what happens at the spiritual aspects. So all these things we did. And she died peacefully in the hospice. But what happened within 48 hours? Because it was a late referral. So this is the change we could have done. If she would have come early, right? If the pain would have reduced, repeated hospital admission would have reduced, and understanding would be more. She could have spent more time with the children, and dignity would have maintained from the time of admission, and advanced care planning we would have done. So one thing from the time of diagnosis, they forgot, people forget to ask from Mira is what most matters to you at the time of diagnosis. This is the picture I want you to understand how the early referral and late referral, makes palliative care to understand. What you all need to understand in palliative care is human dignity is core value. Understand your powerlessness. You can't do everything. Just be with the patient. Make them to understand death is an inevitable reality. So palliative care and hospice care is same. Palliative care starts at the time of diagnosis. Hospice care, it's only last 6 months. So in a hospice care, no curative treatments are possible. This one difference you need to take as a home care, so take home message. And a lot of achievements are there in the country. We have very good Kerala model. They achieved good palliative care. NPPC started, and we trained all the states and complete country. From Karunashaya we have trained. Morphine availability is increased. Lot of capacity building happened from Karunashaya and other hospitals. There are still a lot more things like HSSC today started to sensitize palliative care. We also start with a lot of home cares, to reduce the stigma, and a lot of accessibility to be there. Today it will be like this, how to raise the bar. Over the days when you train, in this one session, we just created awareness. It's a long way to go. And it will happen. One day we will raise the bar. One of our patient, she was in end of life. Look at her, how she lived. All her wishes as a South Indian woman, she said she wanted to tie a sari because she was with CA breast, huge wound. She can't tie 2.5 years with the, CA breast patient. She particularly wanted a Mysore silk blue sari because she said very clearly it was her last wedding anniversary gift. We made the thing happen. We fulfilled her wish. If you want to join your hands, we have IAPC, we have Hospice and Palliative Care Nurses Association. You can join. I welcome Dr. Simha to give his inputs. Yes, sir.
Thank you, Sangeeta. I don't think there's anything really for me to add. Your class is wonderful. And I would rather that if there are any questions, probably we could answer. So there's
Yes.
nothing in the chat box. So if there are any questions in the next 2 minutes, I request people to put it in the chat box. Otherwise, I'll probably take just 2 minutes to summarize. So I think we will wait. And if Dr. Agarwal would like to, check with the others whether there are any questions or doubts or whatever. Otherwise, I'd probably summarize whatever Samhita has said.
If you have any questions, please type in the chat box or raise your hand.
Yes, we're welcome to answer the doubts.
Sir, I think so all are clear. So we can
Very good.
summarize
Yeah,
the
yeah.
session.
So just to to summarize, I think Sangeeta has done an excellent job. There has always been confusion, as she herself has said, that if you tell someone ki palliative care we have started, means it's all over. Yeah. No, palliative care is not necessarily a terminal care. Terminal care is a part of palliative care. And if you start palliative care at the time of diagnosis, there are a lot of benefits that come. Now, tomorrow, people should not say that as a cancer surgeon, if I start palliative care at the time of diagnosis, that means all patients who come to me are advanced. No. Okay. There may be somebody who's got a diagnosis of cancer and he may get well, but then how do I give information to that person? How do I sort out the psychological and the psychosocial and the spiritual questions that the person may have? And even after the person gets well, there are a lot of issues that are there. Like, for example, somebody's had a breast removed, then there is always that body image issue that may come up, or something else that may come up. Issues of sexuality may come up. The other important thing that we must all remember is that palliative care is not only for cancer, right? So any life-threatening, and now we say life-limiting disease, okay? Now a person who's fallen down from a coconut tree and has got, paraplegia, he requires palliative care of a different sort. A person with emphysema, person with end-stage kidney failure, person with end-stage cardiac failure, they all require different types of palliative care. So that is something that you must always remember. And finally, one very important aspect of palliative care is how do you talk to the patient? And a lot of people may ask, why me? Mujhe aisa kyun hua? Now, a lot of people try and answer and say, this is the reason why. None of us really know the reason. And there are ways of approaching this and how do you talk to a patient. Not possible to convey complete, talk about this in a Zoom lecture like this. So these are some of the things that I just wanted to summarize. I think Sangeeta has done. आप हिंदी में मुझे बात करने की जरूरत है. हाँ हाँ, मैं तो तमिलनाडु से नहीं हूँ जो हिंदी नहीं बात करते. मैं मुंबई का तो था, बेंगलुरु में हूँ. तो आप पूछिए क्या प्रश्न पूछना है आपको. लवली कुमारी जी बताइए. मेरा ये कहना था कि पैलिएटिव केयर जो है, लोग सोचते हैं कि अगर पैलिएटिव केयर शुरू किया तो खत्म. ऐसे बात नहीं है. शुरू से भी आप शुरू कर सकते हैं. और अगर पेशेंट ठीक हो गया तो उसके मन में काफी चीज होती है, जैसे बॉडी इमेज. हाँ, मैं ठीक लगती हूँ, लोग देखते हैं क्या मेरा एक ब्रेस्ट छोटा हो गया है ना. हाँ, तो ये सब जो है. और पैलिएटिव केयर सिर्फ कैंसर के लिए नहीं है, बाकी बीमारी जैसे हार्ट के या फेफड़े की जो बीमारी है उनको भी हो सकता है. अच्छा, दीपा जी आपको पूछ रहे थे कि आपको कुछ पूछना है, पूछिए.
Sir, I want to ask, sir, what is the pelvic care? Like in a one sentence, what we understand that, sir?
Palliative care is the active and total care of a person whose disease has gone beyond cure.
Any disease, sir,
Any disease.
at a time.
Suppose a person has got two diseases, तो भी चलेगा ना। ऐसा करके
Okay.
एट टाइम का मतलब क्या है?
Just like any disease happened in
Any
certain, yeah,
disease that is incurable
okay,
और इज सीरियस। अगर किसी को जुकाम हो गया तो आप पैलिएटिव
yeah,
केयर तो नहीं शुरू करेंगे ना।
no,
हाँ, है ना। किसी को फ्लू हो गया या किसी को डायरिया हो गया, हाँ,
no,
एसिडिटी
sir,
बढ़
no,
गया, तो पैलिएटिव केयर तो आप
no,
नहीं देगी ना। तो
no, no,
जिसे हम
no.
कहते हैं ना कि लाइफ थ्रेटनिंग डिजीज, लाइफ लिमिटिंग डिजीज जो है, और आखिर ऐसा है कि जिसका बीमारी ठीक होने वाला नहीं है।
Okay, okay, I got it, sir. Thank you.
थैंक यू। चलो फिर, और अगर कुछ नहीं है तो हाँ, इम्प्रूव, यस दैट्स राइट संगीता, इम्प्रूव क्वालिटी ऑफ लाइफ, दैट इज द फोकस। जो भी हम करते हैं ना, तो कहते हैं ना कि वी डू नॉट एड लाइफ डेज टू लाइफ, वी विल एड लाइफ टू डेज। कि कितने भी दिन अगर कोई जिंदा रहा तो ही शुड बी एज कंफर्टेबल एज पॉसिबल, and not only the physical symptoms, but the social, emotional, psychological, spiritual. So I think everybody is happy and everybody must be wanting to run for lunch. So डॉक्टर मेघा जी, तो धन्यवाद आपको कि हमको एक मौका दिया। तो मैं तो सिर्फ ये जो कव्वाली में मेन कव्वाली सिंगर जो है वो तो संगीता है। मैं तो साइड पे जो चीफ चमचा होता है ना, जो आ करके गाता है, दैट इज माय जॉब टुडे, बिकॉज शी इज फैबुलस, शी टीचेस एक्सट्रीमली वेल, एंड शी वाज वेरी इंसिस्टेंट दैट आई शुड बी देयर with her. So I thank Sangeeta for giving me this opportunity, and
It was
we'll be very
good,
happy.
right?
If there are any other such topics that you would like, please email Sangeeta, and we'll be very happy to take it.
Sir, it was my pleasure you have been with me today. I could have not answered these questions in
नहीं
Hindi.
नहीं 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 नहीं, हिंदी में शायद आप नहीं बोल सकती, वो बात अलग है।
Good.
चलो
Thank you,
चलो।
sir.
Thank you so much, sir. Thank you so much, Ms. Sangeeta. Thank you. This was a very insightful session. We truly learned a lot today.
Thank you.
I hope
Thank you.
the audience must have carried the good insights regarding the palliative care, and they would be able to deliver the same on their home grounds.
Yes.
Thank you so much.
Thank
So
you.
we will sign off today, and Happy New Year and Merry Christmas to all of you.
Yes.
We'll rejoin in new year in 2026 in January with our next edition of Healthcare Insight series. Thank you so much. Namaskar.
Thank you, Meha.